have joined. 18. Okay, now I'm going to start. Are you listening?
Yes, ma'am.
Okay. Now I'm going to start the topic opioids and skeletal muscle relaxants. Now in opioids, these are the drugs of abuse. Opioids are the drugs of abuse which I am going to discuss. Mostly these are used by the drug addicts for addiction, and basically they are also important clinically. They can be used as the analgesic drugs. Opioids, they can be divided into analgesics and antagonists, and I will discuss them accordingly in the serial order. First of all, opioids. Now, what is pain? Pain, it is the ill-defined, unpleasant sensory and emotional experience associated with actual potential tissue damage. Whenever there is tissue damage, any tissue damage has occurred, it will lead to ill-defined, unpleasant sensory and emotional experience. Analgesic is the drug which relieves the pain. Either it can act on the CNS or it can act in the periphery. And there are two types of analgesics: narcotic, opioid, morphine-like analgesics, and non-narcotic. Narcotics are, they act at CNS, they act at central nervous system, and peripheral analgesics are NSAIDs, non-narcotic. Now, this is the pathophysiology of pain. First of all, any tissue injury or any heat, any thermal heat or any electrical stimuli, when there is given, any noxious stimulus is given, it can lead to release of the mediators like bradykinin, serotonin, prostaglandins, which will activate the C fiber, and the C fiber will lead to activation of the neurons in the central nervous system. There will be excitation of the transmission neuron, and there is nerve growth factor production which also stimulates the C fiber activity, and neuropeptide release can occur. It can also lead to substance T and calcitonin G related peptides. These can lead to excitation of transmission of neuron, and when there is excitation or transmission of neuron in the brain, it can lead to pain, that is analgesia. There can be pain. And opioids, these act by stimulating the serotonin and noradrenaline, which has the inhibitory action on the excitation of the transmission of neurons. So when serotonin will be produced, it will inhibit the pain. It will have the analgesic action. So opioids, they stimulate the dissenting inhibitory pathways. And encapsulins and GABA, they also inhibit the pain. They have the analgesic action. And NSAIDs, they act peripherally in the inhibition of the release of mediators like bradykinin, serotonin, prostaglandins. Now opium. Now what is the opioid? Opioid is a drug which is obtained from opium, that is Papaver somniferum. And basically the main drug which I am going to discuss, which is the prototype drug in this class, is the, are you listening?
Yes,
Are you listening?
Yes, ma'am.
Am I audible? Am audible? Okay. Now opioids, these are obtained from the morphine. Opioids, these are obtained from Papaver somniferum, and opioids are the drugs which are obtained from opium. They are morphine is the prototype drug which I am going to discuss. Now, this is the classification of opioids. Opioids, these are the analgesic drugs. These are agonists, opioid agonists. These are natural, semi-synthetic and synthetic. Accordingly, they have been divided. Like heroin, it has the 100 times more potential to cause addiction than the morphine. It is the addictive drug, diacetyl morphine, heroin. 4-codeine. Synthetic is petridine, fentanyl, methadone, tramadol, dextropropoxyphene. These are the synthetic opioids, which are the opioid analogs. And natural is morphine and codeine. Now this is the action of the various opioids on the various receptors. Now there are 3 types of receptors which are responsible for producing analgesia. They are mu, kappa and delta. All these are the inhibitory type of receptors. They inhibit the adenyl cyclase pathway, and they act as the G-protein coupled inhibitory type of receptors, and they lead to decreased release of the calcium, and they also increase the potassium ion or channels. They open the potassium channels and they cause hyperpolarization. They basically cause inhibition of the excitation of the neurotransmission. That is, they have the inhibitory action. So they will cause the analgesic effect. Mu, kappa and delta, these are the receptors which are present in the brain, and these are responsible for inhibitory action, and they reduce the pain. Now mu receptor is the spinal and supraspinal analgesia is produced. Now mu receptor is basically the main receptor which produces the analgesia, and this will also has the mu receptor. Morphine is the mu agonist drug, and it has the uses, the clinical uses, and the actions of the morphine is known by the word sacrum. Sacrum means S for sedation, A for analgesia, C for constipation, R for respiratory depression, U for euphoria, and M for miosis. These are the various actions produced by stimulation of mu receptors. Kappa, it is known to cause dysphoria. That is, there will be hallucinations, visual perceptions will be there, visual and auditory perceptions, and there can be dysphoria. Bad dreams can occur. Kappa is known to cause dysphoria, and delta, it causes respiratory depression and constipation. Now morphine, it is known to cause analgesia. This is the only thing you need to remember, that is perception of pain and reaction to it are altered, and it is known to cause, has the CNS depressant action. Morphine is the prototype drug which I am going to discuss, and it will lead to analgesic effect. It will be spinal and supraspinal analgesia, and it will produce the dull, poorly localized visceral pain, will have the effect of analgesia. Sedation, it has the CNS depressant action at higher doses. At the normal doses will produce drowsiness, but at higher doses it can lead to comatose-like state. So there can be coma at higher doses. Mood is, it produces euphoria, feeling of attachment, and that is euphoric effect can be produced. Respiratory centers, they cause depression of respiratory centers, and this is the main cause of death in the patients which take the morphine, and they cause neurogenic, hypercapnic and hypoxic drive suppression. Hypercapnicness, there will be increased carbon dioxide accumulation, reduced oxygen requirement, oxygen accumulation, and neurogenic. Cough suppression, these are the morphine is also known to cause cough center suppression, and there can be also hypothermia and vasomotor, the region gets depressed, So there can be fall in BP. Hypotension can occur at high doses. Vasomotor center also get depressed. These are the various actions of morphine. Morphine stimulates the CTZ, that is, it stimulates the chemoreceptor trigger zone, which leads to nausea and vomiting, or it can also stimulate the Dinger-Westphal nucleus, which will lead to meiosis, that is, constriction of pupils. Vagal centers, bradycardia. It will cause stimulation of vagal centers leading to bradycardia. And the fentanyl group of drugs, these are used in anesthesia, and these come in the category of the drugs which are used in the anesthesia are fentanyl, L-fentanyl, sufentanil, remifentanil, and these are highly lipid soluble drugs. And these fentanyl is known to cause post-operative rigidity. Post-operative rigidity, muscular rigidity can be caused by the fentanyl. Post-operative muscular rigidity. Neuroendocrine they can lead to reduced ACTH, FSH and luteinizing hormone secretion and increase prolactin and growth hormone. CVS, I have already told you, it has the depressant action. It can lead to fall in the BP, leading to vasodilatation. And there is also histamine release by the stimulation, by the action of morphine. There can be histamine release which can lead to bronchoconstriction and which can increase the precipitate the asthma, and it can also lead to hypotension. There can be depression of vasomotor centers, and these are also used in the treatment of the myocardial infarction pain. Morphine, it shifts the blood to the periphery, so cardiac work gets reduced, so it can be used in the treatment of myocardial infarction pain. GIT reduces the GIT motility, and it causes the constipation, so it can be used in the treatment of non-infective diarrhea, and it can be also used in the spasm of pyrolic, ileocecal and anal sphincter. No tolerance. Now tolerance is morphine is the drug of addiction, so it can cause the tolerance. Tolerance is when we use on repeated use, when we use a particular drug for a long period of time, the effect of the drug it reduces. So we have to increase the dose to produce the desired effect. And the tolerance can occur to all the actions of the morphine except 3 C's. That is, tolerance cannot occur to constipation, to convulsions and to constriction of pupils. These are the 3 C's, that is meiosis, convulsions and constipation. To those the tolerance does not affect. Now smooth muscles, it can cause spasm of biliary muscles. It can cause the biliary tract. It can lead to spasm of sphincter of Oddi, which is present at junction of bile duct and duodenum. So the bile duct is contracting. It leads to increased production of the bile, and it is already contracting. But the sphincter is spasmed, that is, it is constricted. So there will be increase in intrabiliary pressure, and there can be biliary colic. There can be pain in the gallbladder, pain in the bile duct due to spasm of sphincter of Oddi. Urinary bladder, it can lead to sphincter and diffuser is increased tone. It can lead to urinary retention and difficulty in micturition. And bronchi, there can be release of histamine leading to bronchoconstriction. Or there can be, due to histamine release, there can be intense pruritus over the lips. When there is spinal and epidural administration of opioids is given, it can lead to intense pruritus of the lips and due to histamine release. Pharmacokinetics, morphine, it has the first pass metabolism. Mainly, it's metabolized by glucuronide conjugation, And the various routes of administration of morphine are oral, rectal, IV, IM, intrathecal, epidural. These are the various routes of administration of morphine. And of fentanyl is transdermal patch or buccal patch, buccal transmucosal route. And butorphanol, it is by nasal. It is by nasal form. Opioid available in nasal form is butorphanol. Butorphanol is the analgesic agonist antagonistic drug, butorphanol. It is the agonistic antagonistic drug which is agonist at kappa receptor and antagonist at mu receptor. Now morphine is metabolized to morphine 3-glucuronide, which is the neuroexcitatory metabolite. It can cause seizures and can occur in renal failure. Seizures can occur. No tolerance, I have already told you, to convulsions, to constipation and to constriction of pupil, no tolerance can develop. And dependence is when the patient takes continuously addictive drug, that is morphine, there will be dependence. Dependence is, it means that the patient has to take the drug for continuous use without the stoppage of that drug. And it can be psychological and physical. Psychological is when the patient craves for the drug, but there are no withdrawal symptoms when we stop the drug. And physical is when there are withdrawal symptoms when we stop the drug, there will be withdrawal symptoms will be seen. And these withdrawal symptoms can be opposite to the general action of the drug. That is, there can be mydriasis in case of the meiosis, there can be tachypnea in case of the respiratory depression, there can be hyperthermia, and there can be muscle ache, and there can be diarrhea in case of the constipation. Rhinorrhea, lacrimation, chills, yawning, these are the other withdrawal symptoms which can occur. And there can also be sympathetic stimulation. Whenever the person is taking the drug and the patient suddenly stops taking the drug, there will be emergency situation developed in the body, and thus that will lead to increased sympathetic activity. That can lead to palpitations, that can lead to increase in heart rate, arrhythmia, and all these are also the symptoms of dependence. These are the symptoms of withdrawal symptoms. There can be palpitations, there can be tachycardia, there can be increase in heart rate, and there can be chills. Now juices I have already told you, these can be used as the analgesia. It can be used in severe pain like cancer pain. In the cancer pain we can use morphine. And post-operative. In the post-operative, after operation, we can use morphine, and in the acute myocardial infarction, we can use morphine as the analgesic drug. And this is because it can be used in acute left ventricular failure because it shifts the blood from pulmonary to the systemic circulation. And pre-anesthetic medication to reduce the analgesia. To reduce the analgesia, we can give it as the pre-anesthetic medication. Adverse effects will be the actions of the morphine will be the adverse effects. That will be same sedation, dysphoria, constipation, respiratory depression, blurring of vision, urinary retention. These are the actions of morphine, and these will be the adverse effects. Apnea can occur because of respiratory depression. There can be apnea in newborn, and due to histamine release, there can be urticaria, itch, swelling of lips, allergy. Acute morphine poisoning. When the patient takes the morphine continuously, there can occur the acute morphine poisoning. Drug abusers, dose in result 50 mg, IV lethal 250 mg. And the clinical features will be same. That is there can be coma, there can be depression, respiratory depression, there can be meiosis, which is the pinpoint pupil is the main sign of the morphine poisoning. There can be fall in BP, convulsions, death due to respiratory depression. These are the all symptoms and signs of morphine. Treatment is we can stimulate the respiration. We can give BP for the BP, for the fall of BP. We can give IV fluids, vasoconstrictors, and gastric lavage to extract these to expel the morphine. We can do gastric lavage with potassium permanganate. Naloxone is the drug which is used in the treatment of acute morphine poisoning. It is given IV in the dose of 0.4 to 0.8 milligram, and it is short-acting drug. Its action will come immediately, and the patient will have the respiration pickup. Immediately the effect will come. It is the antagonist at mu receptors, mu kappa and delta receptors, and it will lead to stimulation of respiration, and it is the antagonistic drug. It is given IV. Alternative is naloxone. Tolerance, I have already told you, these are the when the patient takes the drug for continuously for a period of 2 to 3 weeks at the therapeutic dose, the patient develops tolerance. That is, at the same dose there are no actions produced. We have to increase the dose for the actions to come, and there can be tolerance can occur to all the actions. I have already told you, the analgesia, euphoria, sedation, respiratory depression, mental clouding, cough suppression. But it is minimal in meiosis, constipation and convulsion. No tolerance will develop. Treatment is we have to withdraw the morphine. For treatment of the tolerance, we have to withdraw the morphine, or we can give NMDA receptor antagonist. Dependence, I have already told you, it can be of two types: physical, when the withdrawal symptoms come, and psychological, when there is only craving and no withdrawal symptoms. Physical, it can be clinical features, that is the opposite to the actions of the morphine, and the sympathetic stimulation symptoms will come. And signs of withdrawal: 6 to 8 hours, peak effect 34 to 45 hours. Psychological is euphoria, indifference to pain, sedation, abdominal effect similar to orgasm. Treatment is withdrawal of morphine, and we have to substitute it with methadone. What is the treatment of dependence? What is the treatment of physical and psychological dependence? Like physical dependence, when there is sympathetic overactivity, we can give beta blockers to decrease the sympathetic action, and clonidine, which acts as the brake. We can give clonidine, which inhibit the release of neurotransmitters, and thus there will be no palpitations, increase in BP, tachycardia. And to reduce the withdrawal symptoms, we can give benzodiazepines to control the seizures, and then and also we can give antidiarrheal drugs. And methadone is the drug which is the long-acting drug. It remains in the body for a longer duration of time. It is used for maintenance. Oral methadone is used for maintenance in the patients of dependence. Contraindication: it is contraindicated in bronchial asthma because it causes histamine release, so it can cause bronchoconstriction and it can worsen asthma and COPD. Head injury is because it causes the respiratory depression. When it causes the respiratory depression, it can lead to increased accumulation of carbon dioxide in the brain. There will be retention of carbon dioxide, and that can lead to increased intracranial tension, and it will interfere with assessment. And there can be also vomiting, meiosis, sedation. There can be vomiting, meiosis, sedation. Meiosis pinpoints pupils and sedation, and there can be sedation by the morphine, there can be meiosis, and there can be vomiting, which can lead to decrease assessment of the patient in case of head injury, reduce assessment of the clinical features, clinical symptoms of the patient due to head injury. So we contraindicate the morphine in head injury patients. It can lead to hypotension, hypovolemia, so fall in BP, so it is contraindicated in hypertension. And it can also cause the severe withdrawal symptom after birth, so it is also contraindicated in the fetus. Undiagnosed in the acute abdominal pain. Now interactions. These are the various interactions, like there can be sedative and hypnotics, they cause sedation, so they can aggravate the sedation, and antipsychotics can increase the sedation, and also they can aggravate antimuscarinic and alpha blocking actions. The antipsychotics, antimuscarinic and alpha blocking actions, like there can be hypotension, tachycardia, it can be aggravated. MAO inhibitors, opioid analgesics, because of high incidence of hyperparexic coma. MAO inhibitors are contraindicated because it can cause hyperparexic coma, and hypertension can also occur, so MAO inhibitors are contraindicated. Analogs of morphine, first of all, codeine. Codeine or 4-codeine is the drug which is used as the cough suppressant. It inhibits the cough center in the brain, and it is used as the antitussive. That is the drug which is used in the treatment of dry cough. It can be used as the antitussive, and also it can be used in the treatment of non-infective diarrhea. Like it can be used in the treatment of non-infective diarrhea, because it also decreases it also causes the constipation. And pethidine is the drug which also does not suppress the cough, less spasmodic action. It has the less histamine release. It has the less histamine release, interacts with new receptors, action blocked by naloxone. It does not suppress the cough center, and it has the less histamine release, which is safer in the bronchial asthma. It interacts with new receptors, action blocked by naloxone. Side effects is, now pethidine is metabolized in the body. Are you listening? Are you listening?
Ma'am. Yes, ma'am.
Am I audible to you?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay. Now pethidine, it is metabolized in the body by the MAO enzyme, MAO-A, and it gets metabolized to MAO-A, and it gets 99.9% gets metabolized by MAO-A, and the rest, which is not metabolized by MAO-A, it gets converted to norpethidine. 1% is converted to norpethidine, which is the excitatory metabolite which causes seizures, convulsions in the body. In these small doses or in the earlier doses, this norpethidine accumulation in the body is less. But when we use for a longer period of time, then norpethidine gets accumulated in the body, and it will lead to increased seizures and convulsions. So short duration of action, tolerance and independence is great, but withdrawal symptoms develop fast. With pethidine, norpethidine can lead to convulsions, hyperreflexia, delirium, myoclonus. And analgesic and pre-anesthetic medication, and during labor, pethidine can be used. Fentanyl. This is the drug which is used in the anesthesia, and it is the drug which causes post-operative muscular rigidity. So, It can be used as a lipid-soluble drug. It causes less histamine release. It can be used in anesthesia, and it has been given as the transdermal patch. It can be used in treatment of cancer or chronic pain, other chronic pain. Methadone is a longer-acting drug. It is used in the maintenance of the drug abuse. Whenever there is abuse by the opioid drug abuse, whenever there is opioid drug abuse is there, we can give long-acting methadone to maintain the symptoms. And it is metabolized by demethylation, cyclization, and tolerance and withdrawal symptoms are low and less severe. Less withdrawal symptoms will be there because it is a longer acting drug. It remains in the body for a longer period of time, and thus we can use it as the maintenance drug to treat the addiction of opioids. Analgesics for chronic pain, opioid withdrawal, less subtle sedative and subjective effects, substitution therapy of opioid dependence, 1 mg of methadone for 4 mg morphine, 2 mg heroin, 20 mg petridine. I already told you it is used as the maintenance therapy. Dextroamphetamine, it is the cough suppressant, analgesic, and it's been used in combination with aspirin and paracetamol. It is the tramadol. Tramadol, it is having the additional action, not only acts at the mu, kappa and delta receptors, but it also acts at the serotonin and noradrenaline release. It increases the release of serotonin and noradrenaline. It means it inhibits the reuptake of serotonin and noradrenaline, and it will have the inhibitory pathway, inhibitory action on the pain pathway. And it is used in the treatment of, it causes less respiratory depression, sedation, constipation and dry mouth. And it is used in the treatment of chronic cancer pain, short-lasting pain due to diagnostic procedure, surgery. Diphenoxylate is the it is the antidiarrheal drug used with atropine. Why it is given with atropine is because it can diphenoxylate and loperamide are mostly combined with atropine. Why? Because whenever the patient is taking any addict patient is coming and he does not get heroin or morphine directly from the pharmacist, so he can get loperamide, which is a drug used in treatment of non-infective diarrhea. So when he gets the loperamide, he can increase the dose of loperamide, and that can increase the abuse potential of the drug. It can be used as the addictive drug. And when we give the atropine along with loperamide, it will cause the side effects. The side effects will increase. Atropine at therapeutic dose will not produce any antimuscarinic side effects, but when we increase the dose of atropine along with the loperamide, when it's used in abuse potential, then antimuscarinic symptoms like dryness of mouth, blurring of vision, urinary retention, constipation can come, which prevents the patient to take the drug at higher doses. So it is used in the treatment. It is used to stop the abuse potential, and then it can be used in the treatment of non-infective diarrhea. Buprenorphine, it is the partial weak mu agonist, and it is used as the long duration of action. It is having the long duration of action. It is the partial agonist at the mu receptor, and it is 25 times more potent than morphine. It is used in cancer pain, anesthetic medication, post-operative myocardial infarction, detoxification, and maintenance of heroin abusers. Because it is the longer duration of action it is having, so it can be used as the maintenance drug in drug abuse. Opioid antagonist is now in opioid antagonist there are two types of drugs, that is agonist, antagonist and pure antagonists. Agonist, antagonists are the drugs which are agonist at one receptor and antagonist at the other receptor. Mostly these are agonists at kappa receptors and antagonists at mu receptors. And the drugs which are agonists at kappa receptors and antagonists at mu receptors can be known by the abbreviation PNB, that is Punjab National Bank, that is pentazocin, nalbuphine and butorphanol. And naproxen, it is not used as the analgesic. Pure antagonists are naloxone, naltrexone, nalbuphine. These are the pure antagonist drugs. That are antagonists at mu, kappa, delta and delta receptors antagonists. Mixed differ from morphine. They will produce kappa analgesia. I have already told you kappa receptors are known to cause, kappa receptor stimulation is known to cause dysphoria, that is hallucinations, bad dreams. So it will be having more psychotomimetic effects. And they will also facilitate noradrenaline discharge, and there will be low degree of physical dependence and produce tolerance to agonistic actions, not to antagonistic actions. Pentazocin, I have already told you, it is kappa agonist and mu antagonist. So it will produce dysphoria, nightmares, abuse potential is low, tachycardia and rise in BP can occur, so it is avoided in cardiac patients. Biliary spasm and constipation is less severe. It can be used in the treatment of post-operative pain in burns, trauma, fractures. Nalbuphine. It is just similar, it is having the similar action to pentazocin. Moderate to severe pain and obstetric analgesia. Butorphanol in postoperative and renal colic. Pure antagonist, naloxone is the drug which is used in the acute morphine poisoning and also in the acute addictive potential. So it will be used in, it is the antagonist of all the receptors. It is given in the dose of IV, it is given in the dose of 0.4 to 0.6 milligram, and it can reverse the actions. It can stimulate the respiration and pupils can be dilated. And those I have already told you: block, placebo, acupuncture and stress-induced analgesia. Drug of choice in morphine poisoning, reverse neonatal, because it causes respiratory stimulation, so it will reverse the neonatal asphyxia, that is respiratory apnea after labor, and partially reverses the alcohol intoxication. It will partially reverse the alcohol intoxication, and opioid dependence precipitates withdrawal symptoms. Naltrexone, it is the drug which is given orally and it is the longer acting drug. It is used to treat the symptoms of the, Are you listening? Are you listening? Am I audible?
Yes, ma'am.
Am I audible? Am I audible?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay. Naltrexone, it is the orally acting drug. Just wait for 2 minutes. Okay, naltrexone is the orally acting drug and it is the longer duration of action. It is having the longer duration of action. So it is used in the opioid blockade therapy of post-addiction. Means it is used in the to reduce the alcohol craving and to reduce the, it is used as the maintenance drug. Naltrexone, it is the less hepatotoxic drug. Thank you. So this is all for opioids. The next topic which I am going to discuss is the skeletal muscle relaxants. Skeletal muscle relaxants are the drugs which are used to relax the skeletal muscles, and these are used in treatment in the anesthesia patients. Like when we have to relax the muscles, we can use skeletal muscle relaxants, and when we have to give the endotracheal intubation, we have to produce the mechanical ventilation, we can give the skeletal muscle relaxants. These are used in intubation of trachea, mechanical ventilation and surgical working conditions are optimized by skeletal muscle relaxants. These are used in the general anesthetic contribution. Now these are being divided into two categories, that is centrally acting skeletal muscle relaxants and peripherally acting skeletal muscle relaxants. In the peripherally acting skeletal muscle relaxants, these are basically divided which are acting on the neuromuscular junction and which are directly acting on the skeletal muscles. The drugs which are directly acting on the skeletal muscles, they are dendrolin, and those who act at the neuromuscular junction, they can be divided into two, depolarizing and non-depolarizing. Depolarizing is succinylcholine and non-depolarizing is D-tubercularium, tanthronium, dexapyronium, pipecuronium, rapacuronium, mivacuronium. These are the non-depolarizing blockers, that is non-competitive, and depolarizing are succinylcholine, and the directly acting skeletal muscle relaxants are dendrolin, and centrally acting are the drugs which act at the CNS to depress the brain so that there can be relaxation. These can be divided into, centrally acting can be diazepam, baclofen and tizanidine. Diazepam, it is the GABA B, it is the GABA B receptor stimulator, and baclofen is the GABA A receptor stimulator, and tizanidine is the alpha 2 receptor stimulator, that is inhibitory type of the receptor alpha 2, that is presynaptic receptor. It acts on that receptor and it produces inhibition of the neurotransmission. And chlorzoxazone and methacarbamol, these are they inhibit the polysynaptic reflexes, and these are used in the treatment. These are also the synaptic centrally acting depressants, that is skeletal muscle relaxants. Now acetylcholine, as you know, the main, I am going to discuss first of all the peripherally acting skeletal muscle relaxants. In the peripherally acting skeletal muscle relaxants, the first is the acetylcholine, which acts at the neuromuscular junction. Acetylcholine is the main neurotransmitter which acts at the neuromuscular junction, and this I have already told you, these are where these are present: skeletal muscle, CNS, preganglionic site. And this is the pathway of neurotransmission of acetylcholine in sympathetic and parasympathetic system. This is how acetylcholine gets released. It acts as the receptors at the muscle end plate, stimulating muscle end plate receptors, which will lead to fasciculations, increased rigidity, increased muscular tremors. Means this is the physiology of the skeletal muscle contraction. Whenever any motor nerve impulse comes, there will be release of acetylcholine. It binds with the neuromuscular receptor at nerve muscle junction. That is, at the nerve muscle junction, the acetylcholine binds with the NM receptors, and there will be depolarization. That is, there will be stimulation of the NM receptors leading to depolarization, and that can lead to contraction of skeletal muscles. Acetylcholine is rapidly inactivated by cholinesterase, leading to repolarization. Muscle is ready for fresh nerve impulse. This repolarization can occur when the acetylcholine it gets metabolized by it gets inactivated by cholinesterase enzyme, and there will be repolarization, and then the muscle it is again ready for the fresh nerve impulse. Peripherally acting neuromuscular blockers, depolarizing blockers, and non-depolarizing blockers. Depolarizing are reject by stimulation of the NM. Continuous stimulation of the NM receptors is the depolarizing blockers. And the drug is succinylcholine, which is the shortest acting drug and is the most used drug. And it is also used in post-operative muscular pain. And non-depolarizing blockers are the competitive blockers which block the NM receptors. Competitive blockers which block the NM receptors. And thus there will be no contraction, there will be relaxation. Succinylcholine, I have already told you it has the affinity but no intrinsic activity. It has the sub-maximal intrinsic activity at the NM receptor. It acts on sodium channels, open them, initiate twitching, fasciculation, and prolonged depolarization can lead to inactivation of the sodium channels. This is how the succinylcholine acts. It actually binds, it opens the channels, there will be fasciculations, and the non-depolarizing blocker, it will act on the receptor, it will block the receptor, and that will be closed. Block receptor, the channel will be closed. Now, succinylcholine stimulates the NM receptor. It is a process by the two phases. Firstly, that is depolarizing phase, which will produce fasciculations and depolarize the muscle fibers, and desensitized phase, that is, muscle is no longer responsive to acetylcholine released by nerve endings. This is how membrane depolarizes, fasciculations followed by flaccid paralysis, increase entry of sodium ions inside the muscle end plate will lead to depolarization, and membrane depolarizes when the receptor gets desensitized. After continuous depolarization, the membrane gets desensitized to the effect of acetylcholine, and then it causes membrane depolarization. The advantages is it can be used in the tracheal intubation, and the side effects are it can be used it causes fasciculation, it causes post-operative muscle pain, and it also increases the intracranial pressure, succinylcholine, and intraocular pressure, and it is known to cause hyperkalemia. And it is the drug which is used in the treatment of malignant hyperthermia, neuroleptic malignant syndrome. And it causes hyperkalemia, so it cannot be used in rhabdomyolysis, nerve and muscle injuries. It cannot be used. It cannot be used in crush injuries because it causes hyperkalemia. And it can also cause hyperthermia. It can also cause hyperthermia. And non-depolarizing blockers is a non-depolarizing blockers. There is D-tubacurarine, which is the drug, which is the longer acting, and then there is vicuronium, rocuronium, mevacuronium, roxacuronium. These are the drugs. These are the actions. They act at the neuromuscular junction, and they antagonize the action of NM receptors. No action action on already open sodium channels. That is, they block the NM receptors, non-depolarizing blockers. They will block, they act as competitive blockers of the nicotinic receptors, that is antagonist. Means this is channel closed, acetylcholine and plate. When there is non-depolarizing blocker is given, it will channel open normally, and when channel is closed, channel open blocked. Effects of non-depolarizing blockers. These are competitive antagonists of acetylcholine at low doses. Ion channel is blocked, and it can also block the pre-junctional sodium channels. And the action is reversed by the non-depolarizing blockers. The action, it can be reversed by acetylcholinesterase inhibitors like neostigmine. Neostigmine is the drug which will reverse the action of acetylcholinesterase, and it will lead to increased acetylcholine. Action can be reversed by acetylcholinesterases at the low doses, but at the large doses, neostigmine does not function. And this is the first agent. This is the main agent, clinically used, D-tubacurarin. It can cause hypotension, it can cause histamine release, autonomic ganglion blockage manifests as hypotension. Other drugs are atracurium. Now, atracurium and cisatracurium are known to cause Hoffman's elimination, that is molecular rearrangement. Enzymatic molecular rearrangement. These are not metabolized by the liver and kidney. These are metabolized in the spontaneous inactivation can lead to ledinosin, which can cause seizures. So there can be spontaneous Hoffman's elimination can occur, and there can be formation of ledinosin, which is known to cause seizures. Nivacuronium, pancuronium, dextronium. These are the various other non-depolarizing blockers. Now, the difference between the non-depolarizing and depolarizing blockers is that succinylcholine causes potentiation. It has increased effect. It can cause hypokalemia, and it is metabolized by pseudocholinesterase enzyme. So it can also lead to succinylcholine apnea. In patients which lack the pseudocholinesterase, there can be apnea in those patients. Then the genetic variation is there. There is the atypical pseudocholinesterase. It can lead to decreased. It can lead to increased accumulation of acetylcholine, which can lead to flaccid paralysis, and it can lead to apnea. Gastric paralysis can occur. It can lead to apnea in atypical pseudocholinesterase patients. And it has no effect on the M2 receptor, and it causes stimulation of the M2 receptor, succinylcholine. It can cause bradycardia. And effect on neuromuscular blocking drug is that it has a decreased effect due to tubacuranin, and the succinylcholine is having the increased effect. And hyperkalemia is caused by succinylcholine, which is prohibited in, it is not given in nerve and muscle injuries like rhabdomyolysis, crush injuries, and other nerve conditions like multiple sclerosis and other conditions. Other actions of NM blockers, this is just same. Pharmacokinetics is that this is same, I've already told you, paralysis and apnea, pseudocholinesterase, because it's the polar compound, so it can cause apnea. Directly acting. Now I've already told you the indirectly acting. Now directly acting muscle relaxant, dantrolene, which is the peripherally acting, directly acting muscle relaxant, it inhibits it blocks the tyrosine receptors. So it inhibits the release of calcium ions in the muscle and plate. and from the inhibit the release of calcium ions from the sarcoplasmic reticulum. So decreased calcium release will lead to decreased contractions and leading to there will be muscle relaxation. Tentrolin is the acting by inhibiting the ryanodine receptors. This is the diagram showing inhibition of ryanodine receptors, decreased calcium release. Now, the directly acting, I have already told you, indirectly acting, I have already told you, peripherally acting muscle relaxants. Now, the next drug which I am going to discuss is the centrally acting muscle relaxants. Centrally acting is baclofen, which is the GABA-B receptor. It will inhibit the post and presynaptic receptors and it will cause membrane hyperpolarization. And diazepam is the GABA-A inhibition. It will cause the depressive CNS and it will cause muscle relaxation. Tizanidine is the alpha-2 receptor agonist, just like clonidine. It will inhibit the presynaptic receptors, inhibit the release of neurotransmitters, and it will have the depressant action. Dantrolene, it is the directly acting, peripherally acting, directly acting muscle relaxant, which is act by inhibiting the ryanodine receptors, and thus it also decreases the release of calcium ions, reduced contraction leading to relaxation. Thank you. My topic is over. Have you understood? Have you understood? Anyone over here?
Yes, ma'am. Yes, ma'am.
Any problem?
No, ma'am.
Okay then. My topic is over. Thank you.